Welcome, and thank you for taking time out of your busy schedule to join us for this live webinar, Provider Education and Training to Increase Use of Intrauterine Contraception, Part 2. My name is Priya, and I am the Membership and Education Associate at ARHP. I will be moderating this webinar. Before we begin, I'm just going to make a couple of housekeeping announcements. If you called in using a phone and you get disconnected, please dial back into the number listed in your GoToWebinar registration email. If you have immediate questions regarding the webinar technology, please type them into the chat box on your screen. There will be a question and answer session at the end of the presentation, and we look forward to answering your content-related questions at that time. 1 hour after the webinar ends, you'll receive an email from GoToWebinar with a link to the post-test survey. Your continuing education certificate will be generated upon completion of the survey. And in 6 weeks, you'll receive a follow-up assessment to gauge how you've integrated competencies into your practice. Finally, please note that this session is being recorded. The recording will soon be available to view on demand on the on-demand webinar section of ARHP's website. Now at this time, I'd like to introduce Wendy Grube, today's presenter. We are thrilled that she could join us today. Wendy Grube is on the faculty at the University of Pennsylvania School of Nursing. Her focus is on promoting access to essential preventive and reproductive health care for underserved populations in the U.S. and abroad, work which has earned international recognition for nurses collaborating with local communities. Wendy, you have the floor.
Thank you. I'm really happy to be here today, and what I'd like to do at this point is acknowledge the grant from activists and Bayer Pharmaceuticals that allow us to present this webinar today. We're very grateful. So I apologize, there's a little bit of a lag in advancing the slides. Sorry, they're coming. Okay. I have no disclosure at this time, and this is the committee who essentially developed this slide deck. Our learning objectives today cover 3 main items. One is the actual insertion technique for the methods of intrauterine contraception. The second is pain management strategies, and the third has to do with troubleshooting and general follow-up. So in our agenda today, we're going to do a little bit of lecture and case studies, as well as some polling with questions and answers. We do have some slides that give you some very useful resources, and then we'll summarize and close. So first of all, we're going to talk about intrauterine contraception insertion. So the timing of insertion, the most important thing about this has to do with the convenience of the patient, as well as the likelihood of your patient becoming pregnant before the IUD can be inserted. So as you can see, you can put it in with menses, and the advantage to that is that you're relatively sure that the patient isn't pregnant. The problem with that is having to schedule it and risk the chance of a pregnancy occurring before you can actually get her in. You can also insert it mid-cycle or any time that you're reasonably sure that the woman is not pregnant. It's more convenient for her. The issue is ruling out a pregnancy, especially if there's been any unprotected intercourse. Now, the caveat to that is using the copper IUD as emergency contraception. So the copper IUD can be used as emergency contraception. This is off-label use within the first 5 days of unprotected intercourse. And it's a great method if someone is looking for a very effective long-term method of birth control afterwards. Sorry, something has happened here. Okay. Now, IUDs can also be inserted immediately postpartum, and they can be inserted after a cesarean section, and that's placed by hand. So that certainly is convenient for the woman, and it has a lower rate of expulsion than post-placental insertion. However, the strings may not be visible on follow-up exams, and so that leads the clinician to wonder whether or not the device is still in place. A post-placental insertion can be done. It's certainly convenient as well. However, there is a higher rate, a slightly higher rate of expulsion at about 7 to 15%, and this can be placed either by hand or by a ring forceps. The issue with postpartum placement is that we know that it's defined as insertion occurring less than 48 hours after delivery. And this really requires somebody who really has expertise in postpartum IUD placement. If you don't have expertise, it's something that is probably best done then after the uterus is completely involuted. So after first trimester abortion, as soon as the uterus is firmly contracted and you can adequately assess the depth of the uterus by sounding, you can go ahead and place that IUD using standard techniques. After a second trimester abortion, the uterus is a little larger, and it may take a little while for involution to occur, and then the IUD may be placed. So this is the kind of busy slide, but I think it's a real helpful algorithm for looking at insertion. So we're going to start with a landmark of the first day of a woman's last menstrual period. If the day of placement is less than 5 days from the first day of her last menstrual period, you can go ahead and insert that IUD right away. If it's been more than 5 days from the first day of her last menstrual period, the first thing you need to do is make sure that her pregnancy test is negative. If she has had any unprotected sex since her last menstrual period, frequently clinicians will offer another method of birth control, such as a combined hormonal method, pill, patch, ring, for the next 2 weeks, with the understanding that it's going to take about 7 days, to count on this as adequate protection from pregnancy. But again, wait about 2 weeks, repeat the pregnancy test, and if that's negative, you can go ahead and insert that levonorgestrel or IUD. Now, if the person has not had any unprotected sex since her last menstrual period, you can go ahead and insert her IUD at that time. So the first poll is here, and we'd like you to answer true and false if antibiotics are recommended to prevent pelvic infection prior to IUD insertion. So the poll is open, and we'd like you to go to the right-hand side of your screen and please submit your answer. So I can see from the results of the poll that 92% of you said that they are not recommended, and this is true. So Dr. David Grimes actually did a systematic review of the literature and found that antibiotics really haven't been shown to reduce the risk of infection when given prophylactically. The data also show that risk of infection are highest in the first 21 days after insertion, which probably speaks more to contamination of a device before insertion, or the possibility of a non-clinically evident infection of the cervix at the time of insertion. But prophylactic antibiotics don't seem to be useful in prevention. And one thing that you should know for sure is, when you're getting ready to put an IUD in, always make sure that you have a secondary unit available. If for some reason that unit becomes contaminated, please set it aside and mark it as contaminated. Contact the manufacturer and they will be more than glad to replace the device. They do not want you inserting a contaminated device into a woman. So just make sure that you do that. So we're going to talk a little bit about the steps for insertion, and these are general steps for technique. Of course, the first and one of the most important things that you need to do is perform a good bimanual exam. That will tell you about the size and the position of the uterus. It can also help you detect any overt anomalies that may be palpable at that time. The next thing that you'll do is insert a speculum that's going to be adequate for visibility. Okay, you need to really see the entire cervix very carefully. And the next thing you would do would be to clean the whole cervix very carefully, usually about 3 times with an antiseptic solution such as betadine, and then apply a tenaculum. And there are a couple of things that clinicians can do to minimize the discomfort associated with the tenaculum. First of all, I think we need, as clinicians, we need to be really careful with what language we're using. So I usually avoid saying the term, this is going to puncture your cervix. I say that your cervix is a curved organ, and we have a relatively straight inserter that we need to use to put the IUD into your uterus. The tenaculum is an instrument that's going to hold onto your cervix and allow us to straighten your uterus. I also tell them that it's going to take, they need to breathe through the initial discomfort, and the cramping and the discomfort usually subsides a bit. And I think just knowing that, a little bit of verbal anesthesia helps them, know that they can breathe through and handle this discomfort. But the tenaculum is really important for us to be able to stabilize the uterus and straighten out that cervico-uterine junction so we can carefully and appropriately insert that IUD. The next thing that many clinicians do is use a topical anesthetic such as 20% benzocaine, which is under the label of Hurricane. The best way to apply this is actually using the gel with a Q-tip on the portio of the cervix as well as the endocervical canal up to the inner os. It adheres pretty well. It works within 15 seconds and the effect lasts about an hour. And it's, as far as I'm aware of, the most potent topical anesthetic that you can use on mucosal surfaces. So the next thing you want to do is sound the uterus. And there are many different sounds available. You want to use a device that's calibrated, that's actually measured. And if you don't have something that is visibly measured, once you reach the fundus of the uterus, after inserting the sound, place a small cotton-tipped applicator alongside the sound, starting from the cervix out to your hand, and then retract the sound and then measure the depth of the sound that was placed inside the uterus. I would recommend using a flexible plastic sound, especially if you're beginning to use intrauterine devices and place them. One of the things that we recommend for beginners doing this is actually to use a pipelle or a small flexible plastic device that's generally used for sampling in endometrium. There's a number of benefits to this. I've seen these actually bend before they will perforate uterine muscle, but they're calibrated very clearly. You can see the depth at which the uterus sounds very clearly, and it's also a mechanism by which you can instill 2% lidocaine. We'll talk about that when we talk about pain management in just a minute. So as soon as you're done sounding the uterus is when you get up change your gloves to sterile gloves, load the device, whichever device it may be, and then get ready to insert the device. So you should not load that device until right before you're ready to insert it. The plastic in the device has memory that if it's loaded too soon before insertion, it can delay the arms reaching the appropriate position that you need to secure it in the uterus. So again, load that device right before you're going to insert it, and then insert the device, and then cut the strings. So when cutting the strings, the recommendation is around 3 centimeters. I would probably recommend, you know, anywhere from 3 to 4 centimeters, just because you can always make strings shorter, but you cannot make them longer. And if you cut them too short, what you have is 2 short projecting strings, and they're a little coarse at first, and they can actually annoy a partner during sexual intercourse. So if you leave them a little bit longer, they will soften with time. Tuck them back behind the cervix, and you can always trim them more if you need to in the future. So it's really important for you to measure the length of the string that's actually outside of the cervix. And what you can do is take the sound and measure the string length and document this very carefully. And again, your documentation on your chart needs to have string length, the type of device, and the lot number, any other issues that you encountered during that time. But that string length is important for any follow-up visits. If you originally cut that string to 3 centimeters and on the next visit you see that that string is now at 5 centimeters, that's a good indicator that the device has fallen down from a high fundal position to sitting in the lower uterine segment, and that can compromise the effectiveness. So here's looking at the Mirena device, and this process is the same for Mirena and Skyla. So you're going to see it's inserter. Oh, sorry. I'm trying to move. I apologize for the difficulty. Sorry. Okay, here's a Mirena inserter. So this is a one-handed inserter, and it cannot be reloaded once it is deployed. So you're going to pick up this inserter, and by moving there's a thumb slide. Take a look at the handle device. There's a thumb marker where if you slide this up to the top, it will automatically load the arms of the device, as you can see at the top, into the tube. So there will be a slight bit of the arms visible at the top of the insertion tube. Okay, then you're going to set the flange at the identified depth that you found during your sounding, your uterine sounding. The next thing you're going to do is insert the device until the flange is about 1.5 to 2 centimeters from the cervical os. At this point, you're going to move the thumb marker down to a first mark on the device, not all the way down, just partially down, and which will deploy the arms. The next thing you need to do is count for about 10 seconds until these arms open up until the appropriate position. And so think of something that you can say for about 10 seconds to the woman, such as, just think, in a few seconds you are going to have a fabulous method of birth control that's going to last you 5 years and make your periods lighter and shorter. Something for 10 seconds. After that time, you're going to move the entire device up to the high fundal position and then fully release the thumb slider. So the mechanism, the process for this is part way in, part way down. So it's part way in the uterus and the thumb slider is part way down. And then all the way in up to the fundus and then all the way down for the thumb slider. So part way in, part way down, all the way in, all the way down. And then cut your strings. So the Paragard insertion is a little bit different. So this has a number of moving pieces. They're not all in one. So it comes loaded with the IUD device and the strings in a clear plastic tube. So what you need to do is, again, with sterile gloves, take the instruments out of the packaging, and you're going to load the arms in a downward position and secure them in that clear plastic tube. Then you're going to insert a solid white rod into the clear plastic tube from the bottom up until it meets the device. The next thing you will do is insert the device all the way up to the uterine fundus. At this point, hold that white circle on the bottom of the solid white rod, hold that steady, and take, with your other hand, take that clear plastic insertion tube and move it down until you feel it'll close to meet that ring. You'll feel the arms pop open. And then without letting go, take that clear plastic tube and push it up to make sure that the device is at the high fundal position. Then you would go ahead and move the solid white rod out first, very carefully. The next thing you would do is carefully move that clear plastic tube, the inserter tube, out. Sometimes a little gentle rotation as you move that out. It's highly recommended not to remove both the solid white rod and the clear plastic tube at the same time, because frequently the strings can get caught in there and you can dislodge the IUD and actually pull it down into the lower uterine segment. So again, you've got to insert to the high fundal position, drop down the clear plastic tube, and then move it back up to assure that the device is in the high fundal position. Remove the white rod, which is a stabilizing rod, and then the insertion tube, and then cut your strings. So the other problem with IUD insertions, or actually lots of different procedures that we do, including taking blood, is patient's vasovagal. So there is something called the applied tension technique that was actually developed in the 1980s by a Swedish researcher who was looking at people who faint when they have their blood drawn. So it's something called, again, applied tension technique, and it's useful if you notice that you have a patient who's about to faint during an IUD insertion or any other gynecologic procedure. So again, when you think about what happens physiologic during a vasovagal response, you have this pooling of blood in the peripheral vessels. So you really want to reshunt that blood back into the core. You're going to have people tense the muscles in their arms, legs, and trunk. So that means tensing your muscles, frequently crossing your arms and tensing those muscles and in your legs and in the trunk for about 10 to 15 seconds. And then relax for 10 to 30 seconds. And repeat this about 5 times. And usually that will abort a vasovagal episode. And usually you can tell if a woman starts becoming cold and clammy, she looks pale, or she says she needs to use the bathroom, she has to defecate. Those are frequent symptoms of an impending vasovagal situation. So this is something that, we found to be very, very helpful. So there are some issues related to IUD insertion that we would consider tricks of the trade. So especially as we're using more and more IUDs in nulliparous women and teenagers, how do you handle a very narrow cervical canal? Because we know that people can experience significant discomfort. Some people have used 400 micrograms of misoprostol a few hours prior to insertion. And you can do that buccally, or some people have done it vaginally, and that's one way that can certainly cause some dilatation of the endocervical canal and that inner os. Some other people have used, again, the 20% benzocaine that you can insert in the endocervical canal, which helps. We try and preload all of our patients with anywhere from 400 to 800 milligrams of ibuprofen about an hour prior to coming in for an IUD insertion. Again, using an endometrial sampler to sound the uterus, they're very, very narrow, and that can be very helpful in getting an idea about how constricted that cervical canal is. Another thing that you can use are progressive dilators, sometimes called os finders. There are a variety of little os finders or dilators that can either be re-sterilized or are just single use that are very useful, especially with teens and nulliparous women. But again, you need to make sure that you visualize the cervix really, really well. So, you know, you need as wide a speculum as it takes to accomplish this. And then other things that you can do is certainly if you have an ultrasound unit convenient, you can determine high fundal positioning with your ultrasound after insertion. So what do you do when you have either an obese patient or somebody who has very lax vaginal tone? You can use a 4-bladed speculum, extra large graves. You can use lateral vaginal retractors. Frequently we put condoms, or actually a glove might work better if you're using a large graves. We've actually put a whole glove over there. Make sure you have really good light. If you have a woman who has a very posteriorly faced cervix, you can try having her do a pelvic tilt, which sometimes will bring her cervix up to you so you're not down on your knees on the floor trying to get her IUD in. So a pelvic tilt can be really helpful. Sometimes even a scopette propped underneath the cervix, but do what you need to do to visualize that cervix really well for the period of time that you need for insertion. So, occasions when the patient after her IUD is to be inserted. This is our next poll. Let's week.
to advance the slides, and thank you again to all our participants for your patience.
Okay. So where we're at right now is follow-up after IUD insertion. So one of the most important things, really critical, is good upfront counseling. It's really critical to helping people have realistic expectations about what they're going to experience afterwards. Some clinicians schedule follow-up visits routinely each week period. Other people just see them at routine well-woman care. Either way, it's really important to tell the patient how to contact you untoward events such as unusually heavy bleeding, unusually severe cramping, or anything that's out of the normal. They need to have a way to contact you. As for routine string checks, in the past we had routinely told women to check their IUD strings after every menstrual period. There actually are no data to support that that has any benefit. So we don't really tell anymore, but certainly if a patient wants to know how she can check her strings, we can certainly teach her that time of insertion. The other thing that we need to make sure that we tell them that is there's going to be an adjustment period, and that's usually the first few months. Generally speaking, the cramps are worse in the first few days. Make sure that she has something such as a non-steroidal inflammatory drug that she can take for management of menstrual cramps in the beginning, and that she should know that it's normal to have some bleeding in between menses. Also, with the levonorgestrel containing systems, it is normal to have significantly decreased amount of menstrual bleeding, and it doesn't necessarily indicate that there is a pregnancy there. If there's any concerns, they need to contact you. So at the follow-up, there are a few very important questions that you need to cover with the patient. And whether this is done in person or whether this is done on the phone, you still should follow up in terms of satisfaction. Are they having any problems? Are they having a pain with intercourse, unusual bleeding, any other side effects? Because you really need to make sure that this is something that's going to work for her and her sexual partner. The other thing is, since most of these IUDs are really, considerably long-term methods, you need to stress that she still needs annual preventive well-woman care. And if this is someone at increased risk for sexually transmissible infections, or if it's an adolescent, again, appropriate counseling about the use of condoms and protection to avoid STI infection and to accelerate screening and treatment. So one of the things that has been useful for many clinicians is what's called a teach-back method. And this is where we really have someone, we give them information, but have them give us the information back. And so some of the questions we might ask a patient is, okay, now that I've done talking to you about this particular method, tell me what you think might be real positive benefits or positive assets for this method for you. Tell me about the most common side effects and what you would do if you experienced them. How would you recognize anything that would be disconcerting after your IUD's in, and how would you reach out to get help? What would you do if you experienced spotting or cramping? So those kinds of questions would help us understand what she knows and if she is prepared to reach out to appropriate resources if she's experiencing a problem. management of cramping. For mild cramping, NSAIDs actually work very well. Again, you can go up to about 800 milligrams every 8 hours. If she has severe or prolonged cramps, you need to evaluate her. At this point, the telephone is neither a diagnostic nor a therapeutic tool. You really need to evaluate her and make sure that there's no signs of infection or perforation or expulsion. You know, severe prolonged cramps could be any number of things. You also need to rule out a pregnancy just in case. If you cannot manage severe menstrual cramps, there may be a time when you need to consider removal of the device. Generally speaking, cramping can get worse with the copper IUDs. However, if this is a woman who experiences severe cramps, she needs to have this kind of counseling and this discussion before the IUD is inserted. The same thing with heaviness of menses. So if a woman is having heavy menstrual bleeding prior to IUD insertion, she needs to have a discussion with you about management strategies for that. And her choice of IUD might be different than a copper. Actually, the levonorgestrine-containing IUD has an indication for heavy menstrual bleeding. So with management of heavy menstrual bleeding with intrauterine contraception, again, they need evaluation for infection or displacement of the device. You want to make sure that there is not a perforation as well. And again, conservative management is important. So you may want to do a CBC to evaluate for anemia. NSAIDs can actually diminish bleeding as well as the cramping. But one of the most important is really ruling out any type of structural steroids that might be contributing to this, fibroids or polyps. Okay. So one study actually by Ronerdog evaluated patients with levonorgestrine-containing IUDs, and they looked at people with unacceptable bleeding patterns after 6 months of use. And what they found in the evaluation is that most of these situations actually happened because of concomitant structural problems such as fibroids. So the issue is that you should really consider ultrasonography to evaluate heavy menstrual bleeding, and for sure check the position and placement of the device. If it is malpositioned, please replace it. So bleeding with the copper IUD, we know that the rates are a little higher than normal. Generally speaking, this improves with time. So again, NSAIDs are helpful with that, and watchful waiting. So complications that can happen, and these are the signs of possible complications that you really need to discuss with patients. So severe bleeding or abdominal cramping about 3 to 5 days after insertion. What we know from the literature is most perforations are not identified at the time of insertion. So, you know, really be observant in the immediate post-insertion period up to a week post-insertion for any signs, again, of perforation or possible infection up to that the first 21 days. Irregular bleeding or pain with cycles, with every cycle. If this is something that's repetitive or continuous, they need an evaluation for appropriate placement of the device. And then ruling out any infections is always very important, especially in that first month. Pain with intercourse actually might indicate that the device has dropped down into the lower uterine segment, or might be partially or completely perforated. Any missed period outside of the levonorgestrine-containing systems, you need to rule out pregnancy for sure. And again, we talked before about changes in string length. You know, be concerned about the placement of the device, and you need to identify where it is. So with an expulsion, these again are more likely to happen post-placentally. They can happen at that time, but they're also really a lot related to the provider's skill at putting it in the high fund placement. Again, we talked about with the copper IUD, it's very common mistake with beginners placement that white rod and the move at the same time. It's mostly pulled. Okay. So, management of sexually transmitted infections. Again, if you have something like chlamydia or gonorrhea that is clinical at the time of insertion, you can do the time of insertion as long as the woman's asymptomatic. If you get a positive result, you treat her. You do not have to remove the IUD. However, the caveat for that is if you have someone who fails to resolve symptomatically in 72 hours, most clinicians would then go ahead and remove the IUD and continue the antibiotic treatment. Again, if they have pelvic inflammatory disease, if they're showing signs of endometritis, again, treat the infection. You do not have to remove that IUD. The risk of uterine perforation is what generally has clinicians concerned. If you use a tenaculum and you gently insert the device, that will actually minimize the risk of perforation. We know that the uterine position and consistency is certainly an important factor. If the uterus is severely retroverted and retroflexed or anteverted and anteflexed, it can make positioning that IUD, inserting that IUD, a little bit trickier. Make sure you use a tenaculum. Make sure that you gently, there's a technique called knocking at the door. So with retraction of your tenaculum and gentle probing with that IUD, you should be able to, again, gently kind of work your way through the inner os without having to apply any force. Force is a considerable issue. The other thing is timing of the insertion after childbirth. There is some risk after that 48-hour period postpartum. There's also some risk that is there's an increased risk of perforation with breastfeeding that has been observed in retrospective studies. But you can minimize that risk through really, making sure that you are very careful in your insertion technique and good observation. So if a perforation happens at the time of insertion that you happen to notice, remove the device if you can and make sure you monitor that patient to make sure she's hemodynamically stable. And then you're going to follow up as appropriate. So, give her another method of birth control. Watch her. That uterus is really quite a tough muscle, and it really should seal up a perforation very well. If the device has been deployed outside of the uterus and you can identify it, you need to refer that patient for removal of the device. But otherwise, you know, if you perforated with the sound, you can just go ahead and insert at the next menses. So if there's pregnancy that occurs with the IUD in place, and again, they are not 100%, although they're fairly close, what you do is, the initial thing you need to do is determine whether that's an intrauterine pregnancy or ectopic. If you can remove the IUD at that time, it would be important to try and do that. If you can see the strings, gentle traction on the strings, can remove that IUD. If you cannot, there's the possibility that that IUD may be in the endometrium or partially perforated. So you need to identify where that IUD is. But you need to remove the IUD to decrease the risk of spontaneous abortion and premature delivery. Also, sepsis has been associated with retained IUDs. So the risk of fetal anomaly is very low. That whole myth of the baby being born with the IUD in their hand is really myth. You know, it's extra amniotic, it's not really near the fetus, and there's no identifiable increased risk in birth defects that, you know, anybody has seen. So we have a 38-year-old woman here who's a G3P2, and she just recently had a miscarriage, and she was on birth control pills, but she has issues with getting refills, and she's not planning another pregnancy for at least a year. She's had a low cell PAP, her blood pressure is elevated, and she has migraines. So, you know, what are the issues that you need to think about for this particular woman? So with the CDC's medical eligibility guidelines for contraception, we can certainly look to that for issues related to what methods of birth control can she use with blood pressure like that. Well, we know that she can certainly use intrauterine contraception, and it doesn't matter in terms of her miscarriage, since she wants to wait to have a pregnancy until at least a year, she should be fine on using a longer-term method of birth control. In terms of her cytology, what we know about low-grade lesions is they're more likely to regress than progress. So at this point, it would be important for her to make sure that, you know, she has a good method of contraception. So intrauterine contraception would be fine for her. They're also fine with migraines, even if she has an ARA, since they, you know, are not estrogen containing. So at this point, she did have an IUD placed, but she missed her 6 weeks appointment, and she didn't come back until 9 weeks. Now, she has had no period since. She had a Mirena inserted. What concerns would you have? So should you give Claire a pregnancy test? Okay, so some people said no, some people said yes. 9% was unsure. So let me move along. Okay. Certainly in this person, you could go ahead and give a pregnancy test. Again, this is somebody that you put an IUD in initially, and you were reasonably sure that she was not pregnant. I'm sorry, I'm having problems advancing these slides again. So a pregnancy test certainly should be done. Other things you can do is check her string and reassure her that with a levonorgestrel containing IUD, it's perfectly normal for menses to be absent or so late that they appear just. The big thing that you need to stress with her is that she's got a good method of birth control, but she needs to follow up with her regular appointment. She needs to see her primary care provider for blood control blood pressure management, as well as her migraines, and she needs to follow up on her cytology. So at this point, let's stop for any particular questions that you have. And again, I apologize for some of the technical difficulties that we've had with moving the slides forward.
Thanks, Wendy, for this really informative presentation. At this time, we're opening the floor for questions. To ask a question, please enter it into the question box in your control panel.
So a question came up, how long after insertion is it normal for a patient to have mild to moderate cramping? And, you know, that's highly individualized. However, you know, most people have cramping for the first approximately 1 to 3 months. That's pretty much the normal range. While for mild to moderate, if you have severe cramping, again, you know, I wouldn't hesitate to reevaluate that person, especially knowing that the incidence of infection is highest in the first 21 days, and also just to make sure that, you know, the IUD placement is proper. Any other questions? And again, you know, really reassurance before insertion and that educational session is really, really important. Here's another question. Is it really okay to insert an IUD with elevated blood pressure? So if you look at the medical eligibility criteria set out by the CDC, it's a level 2. So there's a little risk, but the benefits outweigh the risk. And again, she needs to follow up for, you know, with management of her elevated blood pressure with her primary care provider. So here's another question. During a recent lecture, I heard that it's safe for patients to remove IUDs on their own. Is this true? Well, it's generally recommended that a provider remove it just so you can make sure that the entire unit is removed intact. There have been some situations in which IUDs have been partially perforated into the myometrium and only part of the IUD actually comes out. So for that reason, you know, we really want to make sure that the unit is completely removed and without complications. I would definitely recommend that a provider remove it. For that reason, the question is, any known link between migraine and headaches and migraines? Most of the data on contraception and migraines relates to estrogen-containing contraceptives. If they're again, everybody's physiology is different. I think if one experiences an increase in migraines or headaches that seem to be related to occurrence after the insertion of her IUD, I would reevaluate that. So what IUD is best for individuals who have not had children? Actually, all of them can be used. Many clinicians find that the scala, which is smaller in size and has a narrower diameter of the insertion tube, seems to be easier to insert in a nulliparous woman, but none of them are contraindicated really in nulliparous people. Any other questions? So the other thing I wanted to let you know about is there are, in this slide set, there are a number of resources that you might find useful in your clinical work. So ARHP's website I find very useful, especially the segment for patients to be able to go on and take a look at different methods of contraception. So the Bixby Center, the Guttmacher Institute, the CDC, MEC guidelines, really, really important. And I use that as a teaching tool for patients. I actually sit down with that tool and we can look at, you know, her particular life and set of circumstances and what contraceptives might be best for her. And then ACOG's LARC program. So here's other resources that are available. So to summarize here, a little advanced education on the part of, you know, clinicians and patients together. It's really important to really talk about changes in menses and cramping as normal events after intrauterine contraception, and that can be either a slightly increase in menstrual flow and cramping with the copper-containing IUD, or a decrease or even absence of menses with levonorgestrel-containing IUDs, and they can both be very normal. That reassurance is very important, but also making sure that they know when to contact us in the case of excessive cramping or bleeding, but also talking about, you know, really dispelling myths from the very beginning and helping patients, you know, really understand how this method might be effective for them in their of a good long-term method of birth control. Again, one of the most important things is, do they want a pregnancy within the next year? And if not, perhaps a LARC method might be best suited for them. And here's more ARHP resources, and I'll turn it over to Priya and Caitlin.
Thanks so much, Wendy, and thank you for to all of our participants for joining us today and for submitting your questions. We'd like to, again, give a special thanks to Wendy for her really informative presentation with a lot of practical tips and strategies for counseling patients. It was really, really wonderful. In just a moment, I'm going to tell you how to collect your certificate. But first, I'd like to direct you to our upcoming webinar, which is on June 8th. We hope that you'll save the date. This webinar is the last in our 5-part course on the reproductive health implications of diabetes, and is a special roundtable in which we'll discuss frequently asked questions about diabetes screening, treatment, and counseling. On the homepage of our website, ARHP.org, is a link to a survey where you can submit all your questions, and we hope that you will. And we have plenty of other resources on our website that we hope that you'll check out. Again, it's www.arhp.org. All of these resources, including today's webinar, are brought to you free of charge. And something that we hope you'll consider is joining ARHP as a member to support us in keeping these resources open access for everyone. And now to the post-test survey. You'll receive an email from GoToWebinar 1 hour after the session ends containing a link to the post-test survey. After completing the survey, you'll be able to print your continuing education certificate. Please be sure to print before closing the window. And what we recommend is that instead of clicking on the print button that shows up on the screen, that you right-click the page and print that way. Because sometimes people are redirected to a different page, and we just want to make sure that it goes smoothly for you. But if you have any issues printing, then please feel free to email us at education@arhp.org, and we would be happy to resolve the issue and send you your certificate. Thank you again for joining us today. We hope that you'll take part in other live and on-demand sessions hosted by ARHP.